easily, and then Dr. Anand kind of has the rooms along the backside.
You do the adolescents, or also David Wood. Also, Dr. Wood does.
Yeah, Dr. Wood and I kind of more or less splitting the adolescent clinics. All right. You want to go ahead and get started? We can wait a minute for folks to cycle through, or just ask them to be quiet and move on. What do you think?
Give me a couple of minutes. Let's see if you can sit.
There's generally a brief break.
Yeah. Who is this guy, the front? You know? I know Dr. Stone, the other one. So this side.
Oh yeah, let me see if that'll push back a little bit.
So they can see the board from there, or? Let's see. Not going a little bit that side. No. No. So the first two rows don't see the board at all.
You ready to?
Yeah, let's go ahead.
All right. Could I have everybody's attention, please? So I'd like to welcome everybody to Pediatric Grand Rounds today. I'd like to remind folks to please scan the QR code on this sheet of paper that's on the tables. This also does track attendance, as well as track meal costs and justify paying for meals. So even if you're not claiming CME, if you could scan this and sign in, we'd really appreciate it. So today it's my pleasure to introduce our speaker, MJ Hajianpour. For those of you who don't know him, Dr. Hajianpour is our geneticist here at ETSU. He's building a program and building a clinic in the newly renovated pediatric clinic here. And Dr. Hajianpour has a truly international resume. He earned his medical education at the University of Tehran, PhD at the University of Newcastle upon Tyne,
England.
in England. And also completed his pediatric and clinical genetic fellowship at the University of Miami. And then he came to join us at ETSU, where he's conducting several ongoing research projects, as well as sitting on several professional boards and advisory councils, and has pages of research. So he's here today to update us on some recent advances in diagnosis and treatment of genetic disorders, and let's welcome him.
Thank you. So I'm going to talk about the diagnostic genetic testing today and some of the new treatments, genetic treatment that we do for the patients, which were not available, say, 5 years ago. The testing that I am talking about today are the things that we are actually doing in the clinic. And some of them, of course, are some of the testing that I'm going to talk about are still not available as a service, but it's going to be in the next couple of years. Also, some of the treatments are on a trial basis, and they will be eventually available to the patients. So there's nothing to disclose. And in general, the rate of genetic disorders in newborns is about 3%, 3 to 4% of newborns have some kind of birth defects and congenital anomalies. Half of these 3 to 4% of children, newborns, may have genetic condition. Half a person would be chromosome abnormalities, and 1% would be some single gene disorders. Of course, these figures are somehow old, and with the new technologies that we have with whole exome sequencing, whole genome sequencing, and the chromosome microarray, these figures are much higher now. And 12 to 14% of children at school age with developmental delay will have a genetic condition. 30% of all childhood hospital admissions have genetic conditions. But let's say in this hospital we have 3 admissions per day, and about 20 per week, let's say 100 or admission per month. Do we have that many admissions per month? How many admissions do we have here, including the NICU and PQ? So let's say about 20 per week. So about 30% of those should have genetic conditions, and which is about 6 patients. And in reality, I have to get 6 genetic consultations. Do I get that? Not at all. Do I get 1 per week? No. Do I get 0 per week? Yes. So, and basically, many of these conditions are not diagnosed when the patient's admitted, and they are missed. Out of other disorders, blindness, 50% are genetics, deafness, 50% are genetics, and all cases of patients, children with learning disability, intellectual disability have a genetic condition. So, diagnostic testing. I'll start with the clinical cytogenetics, we were calling that before, which was the chromosome analysis and fluorescent in situ hybridization fish. Now with the chromosome microarray, which is at the molecular level, we call it also clinical cytogenomics. Now, the chromosomes, to start with, at the time of conception, we get 23 chromosomes from the father through the sperm, and 23 chromosomes through the egg from the mother. So the total 46 chromosomes or 23 pairs of chromosomes. 2 of the chromosomes are sex chromosomes. When we have a female, it is X and X. When we have a male, it is X and Y. And when we do the chromosome study, we basically culture the cells, blood cells, and then get let them to divide and arrest the cell division at the metaphase with colchicine and get the chromosome spread. This is chromosome spread. You can analyze the chromosome under the spread and count them to see if they have the right number. And then when you put them in order, based on the length, number 1 is longest and number 22 is smallest. So the length will going to go down one by one, and then this arrangement of chromosome is called karyotype. So karyotype is just presentation of the chromosome in order. So the testing that you order, I order karyotype is not right. You just order chromosome analysis, and then the karyotyping is part of it. And at the very beginning, the banding or the staining of the chromosome was with quinacrine fluorescent dye, and that was Q banding. And then later we had the G banding, GIMSA staining. And based on when you look at the chromosome, you see there are two arms, a shorter arm, which is, we call it P, coming from the petite French word for short. And the long arm is just called Q, just the next letter in alphabet after P. We chose that. And with the staining, we get dark and light bands. And with these first of all, at the time that we had the kinnockering banding or Q banding, there were some bands that were much shinier and prominent. And based on those, they divided each arm of the chromosome to regions, region 1, 2, 3. Sometimes just the whole short arm would be one region or two regions, and the long arm 1 to 3 regions. And that's the maximum that we have. Only one Q has 4 regions, and the rest of the chromosome 1 to 3. And then we had a higher resolution of banding, but we saw that in each region we have bands. We numbered the bands in each region separately, 1, 2, 3, region 1, region 2, 1, 2, 3, and so on. And then with the higher resolution, again, we saw that each band has subband. Again, each band, we numbered the subband 1, 2, 3, and so on. And then again, with a higher resolution, with 800, 1,000 bands, we saw that in each subband we have sub-subbands. So when we want to just pinpoint a location of a break in the chromosome, we use these numbers to just identify the site. And basically, let's say we have a chromosome 22 with a deletion as a specific band and subband. We just write it like 22q1, region 1, band 2, and then dot, subband 3, and subband 2. So you read this chromosome deletion 22q1, 2.32. And if you just read it 22q 12.32, it means that it is in region 12, that there is no such region, as we said, and subband 32, and there are not subband 32. You always read it as one by one. 22q1, 2.32, region 1, band 2, subband 3, subband 2. Okay, this is when we draw the chromosomes like this, it is called ideogram. So the karyotype is just putting the chromosome in order. The ideogram is drawing the chromosome again in order. And the thing that I was talking about, the banding and resolution, you see on this band, for example, in this band we have in region, this chromosome 4, there's only one region on the short arm and 3 regions in long arm, 1, 2, 3. And then if you look at this region, with high resolution, we saw that there are 3 bands, in fact. We count the bands both light and dark. So then it is chromosome region 3, band 1, 2, 3. And then with high resolution, we saw that in this band, 3, 1, 2, there are 3 subbands. And then we put the subband after that, 3, 1, 2, 1, 2, 3. And then again, in this subband, we saw that there are 3 more bands, subbands. And the reason I'm explaining that because later on we will use that again. So the chromosome karyotype that we get on these patients, we have some kind of balanced rearrangement. There is a translocation between chromosome 11 and 22. And if you see on the ideogram, this is the normal 22. This part of the chromosome 22 has been transferred to terminal band of the 11q, and then this part of 11 is transferred to 22. As far as there's nothing missing or extra, this is called a balanced translocation. Not all the genes are intact. But sometimes during this break and rejoinment, basically we may have interruption of the gene and basically causing a specific disease. Now, if in your offspring, for example, in this case, you may, if the mother was a carrier for this translocation, she may pass on normal 11 and normal 22, but in one of her children, for example, she passed on the normal through the egg, the normal 11, and then had non-segregation, and both abnormal 22 and normal 22 were passed on to the egg, and the egg with the sperm. Together, we get 2 normal 11 and then 1 extra derivative 22, which basically has terminal band of 11 and missing most of the chromosome 22. And this is causing a syndrome, Emanuel syndrome, which severe developmental delay, growth retardation, some dysmorphic features, and heart problem, kidney problem. So the balanced chromosome rearrangement basically can be familial, and it may lead to abnormal offspring. And in this situation, sometimes when we have the balanced translocation in one of the parents, you may have just the outcome of it, multiple miscarriages or sometimes infertility because of having unbalanced fetuses. So the next testing the fluorescent in situ hybridization. Basically, we just open up the denature the DNA, open it up, and use a probe and flag that probe with the fluorescent dye for a region of interest. Say we are interested to see if the patient has 1.2 deletion. And we have the probe specifically for that region for Prader-Willi Angelman syndrome, for example. And we flag that with the dye. And if we don't see that probe, that fluorescent dye flagged area of the chromosome under the microscope, which is deleted. So we can, we can do that, basically check the chromosome number as well. If we have the probe against the centromere of the chromosome 21, we can just do the FISH and find out if in a child, for example, a suspect of Down syndrome, we have 2 chromosome 21 or 3 chromosome 21. It can be done in interphase, which means that usually we do for the karyotyping, we do culture the cells, and then usually at least 72 hours to 1 week, and then we get the metaphase spread like this. And if you do the FISH on the metaphase spread on the slide, then we can identify the chromosome, which chromosome is, for example, partially deleted or not. This is good in the case of that we know what to look for, and the patient has, say, deletion of chromosome number 4, and then we have used a probe for the 4q terminal and do the FISH to see if that chromosome is missing or there are some rearrangement. And this is the interphase, which means that we don't need for the FISH to have the culture and doing the spread. And you can, for cases like you suspect Down syndrome, trisomy 18, trisomy 13, that you need to know if you put the patient DNR or do any invasive procedure. You do order FISH for chromosome 13 or 18 or 21. Usually it comes in the cocktail, 13, 18, 21, X and Y go together. And in that situation, you can do just an overnight culture, and the next day do the FISH. And usually in 24 hours or so, you can have the results. Sometimes I hear, should I order FISH? And they say, FISH for what? You order FISH for trisomy 21, FISH for deletion 22q, And therefore, exactly, you have to say what you want to identify through the fish. So chromosome, basically routine chromosome analysis, the karyotyping, now it is not anymore a routine test. And it is now only used when we are looking for balanced type of chromosome rearrangement, like translocation or inversion. And if again, looking for this kind of rearrangement leading to abnormal child or miscarriages, people that couple who have multiple miscarriages or infertility or previous child with chromosome abnormalities, and or there is a relative that has a child with multiple congenital anomalies. Or low level of mosaicism, less than 20%, which cannot be picked up by chromosome microarray that I'm going to talk about. Still, it is used in cancer cytogenetics because of the fusion genes that we get through the translocation, and also deletion of the oncogenes or genes that leading to the cancer based on rearrangement of the chromosome. Now, the comparative genomic hybridization is just was introduced 1992. It's kind of new, but 5 years or more later, it was just commercialized. Now, the way it is done, it is obvious comparative genomic hybridization. You hybridize the patient's sample with different probes, all along the all genome, all the chromosomes. And you have a control normal. You also flag them with those probes. And if we say choose a color for the patient's probe, flag them with the green and the normal with the red, if they're all the same, if the patient has normal chromosome or normal genome, nothing is missing or extra, when you mix these together, you get kind of yellow color, right? That is all matching together. If there is less green, it means that some probes are not there. Basically, some part of the chromosome or genome is missing. Then you have a deletion. If you get more green, you have a less red. And in reality, basically, you have duplication. This is that easy. And the basic of it. And then because it is all over all the chromosomes, we know exactly which chromosome in what side, which band, subband, everything is having the deletion or duplication. This is for the, because mainly we are doing that as a whole genome and the whole chromosome. It is also called chromosome microarray analysis. So if you have a deletion, usually in the linear presentation of that, we will see that there's some depression here. And the way that, because of the probes, we know exactly where they are located. We know exact location of the deletion and or duplication. So in this case, it is on chromosome number 6 on the long arm on region 1, band 5, Q15 to Q16.1, right? So almost one band is missing. And these numbers are the location of the base pairs. And if you deduct this from that, then you get the size of the deletion or duplication. It is about 1.5 meg, right? Million base. And now we have the ability that based on these coordinates and missing area, we can identify which genes are located in this region. And basically based on that, we can suspect what the patient may have related to one of those genes or a couple of those genes. So the next time you see a chromosome microarray results, you know what these numbers are. So also with this, for the microarray, we can use single nucleotide or oligonucleotide, and basically through the oligonucleotide, we can also identify the regions of homozygosity or loss of heterozygosity. For example, if here we have the heterozygosity, and basically this patient doesn't show, it shows the loss of heterozygosity, and therefore we have the region of homozygosity, which is the same as uniparental disomy. So now microarray was introduced in 1992, and now it is considered the first year of testing in any child with multiple congenital anomalies, dysmorphic features, developmental delay, and autism. And sometimes I get the, oh, we ordered the karyotyping. I said, oh, why? So the karyotype, at this level of small deletion, microdeletion, microdeletion, it's not going to be picked up by chromosome analysis or by karyotype. The first thing that you order is chromosome microarray. You do routine chromosome only. You are looking for balanced chromosome rearrangement, translocation, inversion. Again, as I said, the probes are all over the chromosomes and whole genome. Sometimes they call it genome SNP array. They're all basically, they mean the same thing, chromosome microarray. And based on these probes, we know exact site of the deletion or duplication. When we get the higher resolution, we get at the base pair level the number of bases missing or extra. So microarray can detect loss or gain of the chromosome, microdeletion or microduplication. It also manipulates the missing chromosome, the whole chromosome, or extra chromosome, like trisomy or monosomy. It can also pick up the uniparental disomy or loss of heterozygosity or regional homozygosity. It cannot pick up any balanced rearrangement of the chromosome. It cannot pick up translocation. It cannot pick up inversions. So those, if we suspect for that, as I said, for example, multiple miscarriages in a woman or man, couple, you do the chromosome, routine chromosome in those people to rule out balanced chromosome rearrangement. Low-level mosaicism, any mosaicism less than 20% is not picked up by microarray. So if you still suspect low mosaicism, you do routine chromosome mosaic study. Instead of looking at 20 cells on the routine chromosome, you order 50 cells be counted, or 100 cells, or go for fish for 300, 400 cells to be looked at. So when we get the results, deletion or duplication, there are 5 different types of interpretation. It's all either reported as likely benign, or likely pathogenic or pathogenic, and variant of unknown significance. These are based on reported cases. And we have seen, if they find in the literature that deletion on the chromosome 6 that we just showed has been reported in different patients, and it is a known pathogenic variant, then they call it, they report it as pathogenic. If basically they don't see the same deletion in a normal population, and it is de novo, usually we just call it likely pathogenic, And if it is in general population and the reports are that it's not associated with any diseases, it is called benign. But most of the times we get variant of unknown significance, which means that there's still no reports that any patient with this deletion or duplication had any condition or diseases. And in those situations, usually I do the parental studies to see if it is de novo or coming from the parents. And the problem is that usually with these variants of unknown significance, even the pathogenic one, we get variable expression or non-penetrance. The mom or dad may have it the same deletion, but without any symptoms, but the child will be severely affected. So it is variable expression, or if the mom or dad who has the same deletion or duplication are completely normal, non-penetrance it's called. So CMA, unbalanced chromosome rearrangement, deletion, duplication are picked up by CMA. Normal chromosome rearrangement is not. But usually if you have an abnormal child with multiple congenital anomaly, we are looking for unbalanced chromosome rearrangement or genome rearrangement, and that's the first test that you do. It can pick up if the deletion is on one chromosome, heterozygous, or on both chromosomes, homozygous state. So the consensus statement by American Board of Medical Genetics, American Academy of Pediatrics, by gynecology, all is that microarray is the first year of testing. Right? And for any child with autism spectrum disorder, developmental disability or intellectual disability, and multiple congenital anomalies. Now, whole exome sequencing. Now it is coming into picture. We can now look at the whole exome based on a molecular basis, on the base by base. Now, whole exome, you know that the chromosomes are a stretch of compact DNA. And on the DNA, each section of the DNA is a different gene. Now, when we look at a gene, we have exons and introns, or intervening sections. The exons are the parts of the gene which actually splice out and get together and attach to each other, and they cut the intron out. And the exon is translated to a messenger RNA and transcribed to protein. So the exon are actually actual part of the gene that do the work. And overall, the whole genome, probably only 1% of the whole genome is exon. And these are all that do all the genes are located, or most of them, and probably not more than 50 megabases bases are DNA. And with the whole exome sequencing, we can just go and sequence the exons and just forget about the intervening sections. In fact, at the time, we were calling the intervening sections or the introns as junk DNA, but not anymore. Now we know that there are genes, modifier genes, enhancer genes, and different splicing genes that may cause the problem, and basically they all also contribute to the phenotype. So as you see, basically these are exons, and then we only just sequence these areas after amplification and tagging them, and then sequence them. Now, two cases that we had here. This is a patient who was born normal, pregnancy was normal, and actually was discharged home at 3 days of age, then came back the next day with kind of hoarse voice, and later on we found out that she has the laryngeal paralysis, and she had breathing problem and also had low muscle tone and was hospitalized for 30 days or so. And at that time, they made a diagnosis of congenital myopathy. Then eventually they had to put the graft on the larynx, and then at age 5 years. And at that time, they did muscle biopsy, and based on the muscle biopsy, they said the child has SMA, spinal muscular atrophy. Then another 9 years passes until 60s. Our neurologist see the child and doubt the diagnosis, send the patient to me, and I do the molecular testing for congenital myopathy, for SMA, they're all negative, and I do exome and come up with the come up with this Charcot-Marie-Tooth type 2C. The patient actually can talk and can walk, but not normally. But now at age 15 years, through this whole exome sequencing, we have the right diagnosis. Another kid that had severe developmental delay, growth retardation, and no talking at all, and had some facial features, losing subcutaneous fat was low, and clinically I could not make anything. With this triangular face and growth retardation, I ruled out the Russell-Silver syndrome and also Cockayne syndrome, and but they were negative. Did exome, and that was KBG syndrome, and the mother also had the mutation, has some features, some learning disability, but not as severe as the child. And basically, the variable expression that I was talking about, we see that here. Now, the KBG, I know the KBG. A couple of years after I was graduated, got my board, I made a diagnosis on a child with KBG syndrome. There are, of course, facial features, developmental delay, some intellectual disability. And then that was in Miami. And I moved to California. 20 years later, that child, now 20-something, come to my office. And the mother says, OK, you diagnosed this kid with KBG. And the label stays with the patient. Whenever you call the patient, oh, you have Down syndrome or Turner syndrome. So, but the diagnosis was right. And still, I thought that she has a KBG, and the testing confirmed that. But at that time, we didn't have all this technology. The diagnosis was just looking at the patient, having that Smith book with the malformation, page by page, looking at the pictures to see if the patient looks like one of those syndromes. Now the faster way to do the sequencing for regions of the genome that you are interested in, for a very specific disorder, then we can do kind of high throughput testing, like the next generation sequencing. You know, just you go only on the regions that you are interested. You forget about the section in between. So, for example, I order Noonan syndrome panel. There are 6-8 genes that they look at, or rasopathies. And then just looking at those sections of DNA that are associated with disease and the mutation. Or we do it also in cancer panel. So 80 genes or 100 genes, it goes with next generation sequencing. And then we can apply that for genome sequencing or transcriptome, and basically chip sequencing, epigenome. And basically, it has increased the turnaround time was much shorter, the cost is much lower. And one technique is just massively parallel sequencing. You can do all the genes in parallel, the sequencing at the same time. And again, the advantage, turnaround time is shorter, the cost is lower, and you can look at all the genes, and even the low-level mosaic system can be picked up by this. Then we come up with the whole genome sequencing. If you remember, some of you, that we started the whole genome sequencing project, a big project in 1990, and completed in 2003, 13 years, with $9 billion budget. That was worldwide. And now, from that on, just in 10, 15 years, we have come to the era that we can do whole genome in 1 day and with a cost of $1,000. Of course, this is the personal medicine type of thing. It is not as detailed as that we do when you do the genome, whole genome for the diagnosis. But 13 years of doing whole genome to, again, just a couple of days or 1 day doing the whole genome. That's how fast we are progressing in this field. Now, another area of making diagnosis and screening, for the Down syndrome and the prenatal genetics type of thing, through the alpha-fetoprotein AFP screening and other markers. During the first trimester or second trimester, we can suspect the neural tube defects or Down syndrome and some other triploidies, sometimes the trisomy 18 as well, and monosomy X. And through the this AFP or maternal serum screening and fetal ultrasound, the good number of Down syndrome could be picked up to 95%. And the maternal serum, now, in the last 5-6 years, we know that we can also recover the fetal DNA through the maternal serum, and I'm going to go over it and do the testing on the fetal DNA through the maternal blood. These are all non-invasive testing, and then if you want diagnostic testing in a pregnant woman, eventually if these are abnormal, the risk is high for Down syndrome, or you see through the maternal cell-free fetal DNA possibility Down syndrome, you have to do still the chorionic villi sampling, amniocentesis, and fetal blood sampling also rarely done. And now that we have all this technology for a diagnosis, we can also do pre-implantation diagnostic testing, which is basically at the level of blastomere 4 to 8 cells. If you take 1 cell out, the embryo is not going to be damaged. And 1 cell you should know what you are looking for, a mutation or a deletion. You can do FISH or molecular testing. And if the child is not affected, doesn't have the mutation or the deletion, you put the embryo implant in the uterus, and then it would be a normal child. But we do that right now, pre-implantation genetic diagnosis. Again, you may hear that sometimes. And it is for high-risk recurrence, like cystic fibrosis, 25%. You can do that and just choose the embryo that doesn't have 2 mutations, that's autosomal recessive, and choose the embryos without either any mutation or just be carrier. Or for autosomal dominant disorder, that 50% recurrence risk. And it is only done when you know the mutation. So basically, this is the prenatal screening, maternal serum screening, and then recently we have NIPT, non-invasive prenatal screening, or some people call it testing. Again, through the cell-free fetal DNA circulating in the mother's blood, we can separate those DNA, and we're choosing the probes for the, let's say, chromosome 21, or these are for also 18 and 13, and X and Y, and some deletion. We can test the fetal cells or DNA to say if the child has one of those conditions or not. And if we get the positive results, still you have to confirm it with the amniocentesis and CVS. So this is basically right now, already about 20% of the 4 million babies born in the USA each year are being tested this way. It is replacing the amnio and CVS. The rate of doing amnio and CVS has gone down during the last 5 years to from 90% to minimal number, 10%. So, here we have in the maternal both maternal DNA and also the fetal DNA. Through some of the sequencing specific to the fetus, we can separate the fetal DNA and test them for the trisomy of those chromosomes 13, 18, and 21. And if we know some deletions, also through the CMA, we can look for a specific deletion that we want. These are different companies, different names. Sometimes you hear that. The LabCorp, we call it Maternity 21, variola, but basically these are all NIPT or NIPS. Now, we have all the diagnoses from doing chromosome only, we are all the way to the whole exome sequencing, whole genome sequencing, next-gen sequencing. And these are actually, we are using these in our clinic. 5 years ago, there was nothing like that. Advancement in treatment of genetic disorders. Fabry, the enzyme replacement therapy, again, Fabry, you know, there's a kind of disorder that may happen during the childhood or later on with the severe pain in the extremities, angiokeratoma and hyperstasia. That's a storage disorder, and basically the kidney might be involved, and usually they have the end stages of renal disease. And through the recombinant DNA, we could produce the enzyme and have through the enzyme replacement therapy. 2 companies are making the enzyme fibrinogen from Genzyme and Replagal. And we have here only one patient I have that I'm following with this treatment. And the same thing with Gaucher disease. Again, it can be very severe during the neonatal period or childhood, or can be very mild and picked up in the adulthood. The same way, now enzyme replacement therapy is done for Gaucher, and these are the 3 different companies producing the enzyme. I go through the spinal muscular atrophy and different type of treatments that are now available for this. And you know, this is a progressive muscle weakness and resulting degeneration, loss of anterior horn of the cells, and in the spinal cord and brainstem. So there are 2 genes for SMA. SMN1, that's a main gene, and both of them are on 5q13.2. One of them is on the lower part, telomeric, and one of them is close to centromere, but next to each other. The SMN2 is producing the same SMN protein, but it's not as complete and full size as SMN1. And therefore, these are autosomal recessives. If both genes are defective, then you have basically the spinal muscular atrophy. Usually, the patient at the neonatal period may present with severe hypotonia, breathing problem. 95 to 98% of them are due to the loss of exon 7 on SMN1. So that's the location, and Sometimes you may have 2 copies of SMN1, but both of them on one chromosome. We say that in the cis stage and cis phase. And the number of chromosome, the gene SMN2 can be varied from 0 to 5. So we may have 1, 2, 3, 4, 5 copies of SMN2. They only change. They only differ by 5 bases, but still the protein is not the same. So the different presentation from SMA0 to SMA4. SMA0 is kind of prenatal onset. The baby usually dies by 6 months of age, and then SMA1 usually by age 2, and SMA3 up to age 25 they survive. SMA 3 and 4 might be kind of normal. If some of the previously we were calling SMA1 and 0 Wernicke-Hoffman syndrome, the severe hypotonia. And we didn't have any diagnosis at that time that I was doing residency, but now any baby with hypotonia, usually we go after this also. Another thing, babies with severe hypotonia, we also rule out the Prader-Willi syndrome. So now there are some treatments for SMA. Either you can stimulate the production of the protein if both SMN1 are defective or not working or not functioning. You can stimulate SMN2 to make proteins through the different substances, some medications like phenylbutyrate or valproic acid, and especially the quinazoline may actually stimulate the SMN2 at the splicing level and make the exon 7 to be more active and making the protein. So some of these studies are still on animals. And now, the RNA-based therapy is very interesting. It is right now hot, and this is the thing that maybe in the next couple of years, this is actually can be offered to the patients. And as soon as you diagnose the patient with SMA, we can use right now about 2 different products, ASA 1027, and there are two other products from Novartis and the Roche, that again they are going to stimulate the SMN2 splicing sites to do the transcription, stimulate or increase this transcription at that exon 7, which is the major part of the gene causing the disease when it is deleted or mutated. Now, with this, and the diagnosis that we have, right now we are talking at the state level that to include the SMA molecular testing in the newborn screening. And already it is on a trial with this technology to treat the SMA. Also, there are trial on SMA on gene therapy, which means that basically you incorporate the normal gene in a virus, a vector, and send it to the body. And the problem is that how to send a virus to the tissue of interest, in this case, a spinal cord. But again, these are the studies are being done, and eventually on an animal, we have got some response. CRISPR. So now you hear this over and over through the news everywhere, and I tell you what it stands for, and you are going to memorize and don't forget it, right? So clustered regulatory interspaced short palindromic repeats. So there we have palindromic repeats of DNA that basically regularly we are talking about the prokaryotes in the DNA. And then next to it, there is a gene called Cas gene. The whole CRISPR and Cas system is used to cut the DNA, and if you have a defective gene, take that gene, defective gene out, abnormal gene out, and put a new gene. It is called gene editing. So it is really something that is going to happen. And when the Star Trek that we were watching, Dr. McCoy was having some computers and going over the patient, sequencing and identifying the disease, and then doing the gene editing. And this is that was a movie, but it is now happening. And we have actually right now a company making the handheld sequencer, DNA sequencer. So the version of CRISPR-Cas, Cas9, which is a modified type of it, is now used for gene editing. And before that, I don't know if you know palindromic, what it means. It means that when you read the bases from 3' to 5', or 5' to 3', they are basically the same. It is like palindromic words. If you, the word madam, if you read it from right to left or left to right, is the same. Another good one is race car. Race car, right to left, left to right. Or you have it in numbers, 102, 5, 201. Right or left, the same. So in double helix DNA, on one side we have this palindromic sequence, and then the complementary of it is basically C2A, H2C, but that one is also palindromic. And the prokaryotes, these are kind of interspersed in the DNA, and with the sequence synthetic guide RNA, we can identify the place that you want to cut the DNA, and through this system. This is a prokaryotic system. And then it has some nuclease that cuts the DNA. And that's the way it's done. You cut the DNA in the area that you want. You take the bad DNA out. You put the good DNA in. It is being done on bacterial cells, on zebrafish, and human cells. So at the animal level, at the most, they could do do the gene editing with CRISPR-Cas9 on ALS, and the survival rate was high, increased. All right, so I'm on time. So that's the future of us 100 years from now. The robots are doing everything, sequencing and treatment, and thank you very much. Now, let me just, these are the questions that for those who are getting the CME, what is the first year genetic testing? Match the numbers with the figures. Do you want multiple congenital anomalies? What? A child with developmental delay, chromosome, routine chromosome, screening for metabolic disorders, microarray, whole exome. What do you choose? A child with autism. B? D. D for which one? Autism? Okay, D for all of them. Chromosome microarray, the first year testing for any child with congenital anomalies, with dysmorphic features, with developmental delay, with autism, right? How do you screen for some of the metabolic disorders in a child with failure to thrive? Plasma amino acids, urine organic acids, sweat test, stool testing for cystic fibrosis, plasma carnitine and acyl carnitine profile, carbohydrate deficient transferring, chromosome microarray, all of the above. All of the above. And which of the following therapies is currently considered as either on a trial basis or research for each of these disorders we just talked about? Gaucher, recombinant DNA. Fabry, recombinant DNA. Amyotrophic lateral sclerosis, at least in mouse, we know that we do CRISPR. Spinal muscular atrophy, RNA-based therapy increases the production of protein through the SMN2. And obviously, when the child has SMA1 and both genes SMN1 are defective, if there is no SMN2, you cannot help it. There is no SMN2 to stimulate the production protein. So at least you have to have one or two, better to have 2 copies of SMN2. So, but you may have 0 copies to 5 copies. The more you have the copies, the better. And those people who are milder and present the disease later on or are completely normal, they have more copies of SMN2, compensate for the SMN1. Some type of cancer right now is being done, again, is CRISPR, gene editing. All right. We don't need that. All right, thank you very much.